Your spine is not fragile. It's not made of glass, although there are so many providers that make you feel that way. That if you're not walking perfectly straight, sitting perfectly straight, or it's something's out of alignment and you're susceptible to injury at every corner, and that you can't even bend over to pick up your phone without having a perfectly straight back, otherwise something's going to go out. Yeah, that's the thing that's creating chronic pain and is trapping people. So one of the worst things you can do is get low back pain and then put your life on hold. You wake up the next morning, I have back pain, so I'm not going to go on my walk. I'm not going to go to the gym. I'm not going to go ride bikes. I'm not going to play with my kids because I'm afraid I'm going to damage my back further. So we all know this is based on the evidence. This is not my opinion. The number one treatment for musculoskeletal pain is education and exercise. I would just say 80-20 rule, where 80% of your care should be in an active therapy bubble and 20% doesn't have to be, but can be in a passive therapy, manual therapy bubble. 80% of human beings alive will experience low back pain at some point in their life. It's the number one disability in the world. 60% of people will experience low back pain at some point in the last 3 months that they might be dealing with.
Hey everyone, Derek Hines here. Welcome to the podcast where I'll share with you the patterns, insights, research, and technologies that we use in my own pain and performance practice to help people improve their health, speed their healing, and increase their longevity. Thanks for listening. I hope you enjoy it. Good stuff, Dr. Grant Elliott. Welcome to the Pain and Performance Podcast, man.
Thanks for having me.
Let's catch people up a little bit. So how did you start to get interested in disc herniation, low back pain, sciatica? Was this like a pure need where you're like, okay, there's so many people suffering with this that aren't getting great care, or was there a personal history there?
Both. So I used to competitively race cross-country mountain bikes. And at that particular level, I was getting scholarship opportunities. This is right before I was going to college. And so I was getting scholarship opportunities. And at that point, it's pretty high intense races for anywhere from an hour and a half to 2 hours. So you're on a bike at a rounded position for a long time. And my low back started flaring up. And I started having to get off on the trail, in the woods, stretch my back out, trying to figure out how I could finish the race. And it got worse and worse and worse and worse. And so I saw what I would refer to as a traditional old school chiropractor that, took an x-ray, your spine's crooked, got to realign you, come back, 3 times a week. And I didn't know any better at that time. Young and naive, and my parents didn't know any better either. So that's what we did. And shocker, got no results, and had to quit racing, lost my scholarships, and that was it. And then, long story short, I then met a rehab movement-based chiropractor a few years later, and I was like, what you're talking about and what you're doing is completely different than what I experienced. If I'd got this, my story would not have been the same. So I want to become one of the best who's providing this so that other people don't have my same fate, if you will. So then I went to chiro school. Just everything I did was movement, rehab. Everything I do was not taught in school. And and then as I started to grow my social media and grow my audience, I was posting about everything, all types of issues, but the audience told me, that my low back videos got the most views. I got the most questions about low back, disc, and sciatica. And so a combination of my experience dealing with low back issues and then seeing that, oh my gosh, this is just a giant need. It's the number one disability in the world. That's what turned me into being, okay, I'm going to become, the number one online low back program in the world. And I'm just going to make everything I do about just that. And that's what we did.
Yeah. It's funny. I get asked all the time, how'd you circle back to this? And I'm like my family's in healthcare. I grew up following my grandfather, who was a little rural primary care physician around. He'd see patients with a bratty little grandkid nipping at his heels, and they're like, oh, did you ever get good therapy or anything like that? I was like, no, I had many injuries and all the care I got was bad.
Yeah.
So maybe it imprinted don't do it that way. Do you think there was some of that carried over? You're like, yeah, I know that exists, but I'm gonna leave that over there.
100%. Yeah. It's there's a lot of people you meet in different professions where they went to that profession because they had a success story. They'll go, it helped me so much, so I wanted to do it too. And I'm the opposite. It's I was failed so badly that it made me want to make it better.
Yeah.
So yeah, I know what not to do. I'm going to do the opposite.
Yeah, I'm with you. So you talked about like this being the number one disability. For those who are listening to this and don't have back pain, that's amazing. I'm very happy for you. But let's talk about how important this subject is. So like, how many people are going to deal with back pain? How many people are going to deal with sciatica on a national level? It's been a while since I looked at those numbers, but they were scary when I did.
Yeah, so 80% of human beings alive will experience low back pain at some point in their life. It's the number one disability in the world. 60% of people will experience low back pain at some point within the last 3 months that they might be dealing with. So it is an overwhelmingly majority, the highest pain and disability suffering of the world, like by a landslide. It is in first place by a long shot, which is not a good first place. That's not a victory for anybody. It's a testament to, one, it being such a common region of complaint, but also it's proof that majority of the way healthcare confronts this is vastly inadequate. They're not doing their job because it's largely built around the biomedical model and all these other things that we can get into that overcomplicates it and can chronify pain further. So it's just not being managed appropriately.
This is a massive question. So I preface this with that this is probably not the best question. Why? Why do 70% of people have back pain today? Like that number seems insane. I feel like our spine is brilliantly designed. Why do you think we're having such this massive amount of people who are dealing with it?
Yeah, I think there's two main things I typically trace it back to. There's a narrative. I think one is a narrative that's developed by both medical and just public, society perspectives, and I'll touch on that. And then the other is just the biomechanical demands of our body, which shows that, hey, our low back is a hinge point for basically everything we do. And this isn't a bad thing. That's why our spine was built to move. That's why our spine was built so strong and so robust. It's perceived not to be that by societal narratives, which I'll get into in just a minute. But our spine is incredibly strong. Do we use our spine a lot? Yes, it is a primary lever arm. Anytime you're sitting, bending, lifting anything, your low back is the lever arm. So are you using your back all the time? Yes. So unlike if I were to, let's say, hurt my elbow, okay, I can just use my other arm. Not really a big deal. I'm not going to become that worried. But if I'm using my low back a lot, it's going to become typically much more worrisome to me because I have to use my low back for everything. So it's a primary lever arm in your body. You're using a lot, you're stressing a lot. And so therefore it can be somewhat easy to have a normal pain experience, a normal flare-up experience. No big deal. But now here's where narratives come in. We're all going to experience low back pain at some point in our life. That's not a big deal. It's common, it's expected, but it's what we do with that pain that can lead to suffering and disability. So if we experience a normal episode of low back pain, here's where the medical and societal narratives can then destroy that person if they're the wrong one. So I gave the example of elbow pain earlier. If I wake up with some low back pain and my mindset is, oh, no big deal. I just slept the wrong way. I understand that back pain is highly recoverable. I'm just going to continue the rest of my day as normal and I'm going to be fine. If that was everybody's mindset when they experience low back pain, it would not be the number one disability in the world. No, not at all. But that's not the understanding of most people. The understanding of most people from society is, oh my gosh, I know all these people who have back pain and they all get surgery and they all complain about their backs all the time and they all say it's never going to get better. And it is my perception based on what I've heard within society that, oh, low back pain means you're going to, be in crutches the rest of your life. That's societally pushed because of their misunderstanding, which can be driven by then the medical narrative. And the medical narrative is, yeah, you get a low back issue. All right, we got to immediately do an MRI or an X-ray to see what the problem is, which we know is not true, does not follow clinical practice guidelines. You're going to see things that are not related to these back issues. And following a biomedical model, you're looking for something to blame. So, oh, I see what the problem is. I see this disc bulge. That might have been there for the last 5 years and is never going to cause a problem. but I see this disc bulge. So now the solution to that is removing that from the image. We need that to be off of the image or to be fixed to what we deem the corrected position in order for you to feel better. So they resort to, needles or knives to resolve that, or to other procedures involved. And that is the narrative. Like, it has to be cut out or fixed, or a procedure to some capacity to fix it. Otherwise, you will remain stuck like that. Like, majority of people think disc herniations can't heal, which is insane, which is absolutely crazy. 97% of disc herniations can recover without surgery. There's a massive study in 2020. There's 280,000 people. 97% recover without surgery. But medical narrative, this needs to be cut out. You need a procedure.
Got to be done.
Now societal narrative, can't be fixed without surgery, or you're going to be stuck like this. And now we have the number one disability.
Yeah, I think whenever we look at this, that's the biggest thing that we hear is like, can this heal? A, I'm sure you get that all the time. And B, like, what does that look like? What are we talking about? Is this a year that it takes for this to heal? Is mine too bad? If that study was really interesting to me about the severity compared to healing, what in terms of like correlation, like how severe was the disc herniation and then how much healing happened. You want to dive into that a little bit? I thought that was something that jumped out, that we tell a lot of patients about.
Yeah, so there's two layers of semantics that need to be confronted within that. So first off, what does healing mean? So I don't want to get too in the weeds here, but some people will think, well, healing means it's not on an image. Well, that's not what healing means. If you can take two people and let's say they both have a disc bulge, okay, and within 3 months, 6 months, if both of them are 100% pain-free, they can do whatever they want and they're not going to have an issue, I would call that healing. But if you took an MRI, both of them, on one of them, the disc bulge might be gone, but on the other one, it might not be. It might still be there. Does that mean person number 2 did not heal? No, it does not mean that. They still healed, even though there might still be presence of a visualized bulge on an MRI. That does not inherently mean there's a problem or that there's pain involved. So that's first thing.
Yeah,
is when we use the word heal or recover, you want to focus on function. Not just tests that can prove evidence of something. It's function. Because the only thing that matters is if you can do what you want to do. And if you flip it, let's take someone with a disc bulge, 3 to 6 months, the disc bulge is gone, but they still have pain. They're afraid to move. They can't do anything. Is that person healed? No.
Right. Yeah, we see that all the time. The surgeon said it's great. Like, well, I don't feel great.
Yeah. Exactly. So that's semantic number one. Now the other one is severity. This is always interesting. Oh, they said my disc herniation is really bad. Well, what determines if it's bad? We should determine severity based on symptomatology. That is the determining factor if something is severe or not. But a lot of people trace that word back to how big it is. So I prefer to not use the word more or less severe. I prefer to speak on the terms of size. So just bigger or smaller. And what we know based on the evidence that you're referring to is that what we see is a higher percentage of healing and a higher percentage of recovery the bigger the disc herniation is. And medical society and lay public believe the opposite. Oh, it's a big herniation. It's bad. Surgery is the only thing that's going to help this. It's an 8-10 millimeter herniation. Oh my gosh, there's no way this is going to heal. That's not what the evidence shows.
Yeah.
The evidence shows that, hey, good luck. Like, that's a good thing. Like, you have a higher chances of recovering, and that blows most people's minds. So that's why we don't want to use the term, high severe, the bigger it is. No, severity should be dictated by the symptoms that you have present. Because you could have one person with, let's say, a 3 millimeter herniation, and they could have radiculopathy, sciatica shooting down the leg, extreme, limitations in mobility, tons of nerve tension, can barely move. And you could have someone with a 8, 9, 10 millimeter herniation that's like, yeah, I got a little bit of back pain. It's like, well, obviously in that scenario, the 3 millimeter is more severe.
Yeah.
So yeah, these are the fine points that we want to discuss.
That's the stuff. Look, I feel like we've done people such a disservice on spine stuff because of all of these little things that you know, like you said, it's like it seems like it's semantics on the surface, but when you add a bunch of them up, it just creates a really negative view of what spine health looks like and what we should do when we have an issue with spine problem. Let's take a quick moment because we get this stuff a lot to break down like herniation versus bulge versus extrusion, sequestration. Can you just give people like the elevator pitch of those?
Yeah. So like generally speaking, if someone's going to say the word herniation, that kind of is like an umbrella term that kind of encompasses all of them, because a bulge, generally speaking, and this is how most people use it, a bulge is just going to be a smaller version of a herniation. That's how most people designate it. Now, technically, there's different shapes to them. A bulge is going to be more of like a diffuse, like broad pattern. A herniation is going to be a little bit more finite, like an acute pinpoint. So like there's technically a different shape to them, but the manner in which most people speak about them, herniation is going to be an umbrella. And within that umbrella, we can go bulge, protrusion, extrusion, sequestration. And those are the different sizes of it. So we can say that a bulge is going to be the smallest size of a herniation. A protrusion is the second greater. An extrusion is third greater. Sequestration is fourth greater.
Gotcha. Yeah, easy. So if we're like going through this process, one thing like you mentioned is the severity not being just on the image. Like, and I think that most people listening to this will be like, I had one and we looked at the image. I know there's a lot in this, but if somebody's listening to this and they had a back injury, in your mind, what does a great assessment look like? Like if you go into your doctor, what should that look like? Probably what shouldn't that look like?
Yeah. The first answer I'm going to say is this. So if you have low back pain, how should your first visit not look? Your first visit should not look like a 1 hour wait, going into an office, saying I have back pain, and you being mostly interrupted to just low back pain. Okay, I'm going to go ahead and write you a script for an MRI. I'll see you in a week. That should not be the first appointment or an assessment for low back pain. No, you should be in an efficient location, not making you wait forever, and you should be provided adequate time. You should be given time, a thorough history. So a proper history alone, so history meaning talking. What are you experiencing? What are your past experiences? Tell me about your lifestyle, your understanding of pain, what you believe is going on. Any relevant history that individual might be able to relay in regards to their pain experience, that can help you formulate 85% of the diagnosis is typically what's referred. So you should be asked a lot of questions and you should be telling your story. That's how the first portion should be. And then there should be a thorough movement-based analysis because your spine was made to move. So what better way to assess your spine than to move it? So if you're not being provided some degree of movement analysis, then you are not in the right place. So what do I mean by movement analysis? Let's make this very, very basic. Okay, individual dealing with low back pain, let's understand it together. I would have them simply stand up. Hey, bend forward to try to touch your toes. How does that look? How does that feel? Okay, bend backwards. How does it look? How does that feel? Give me a squat. Let's put our feet together and let's rotate each way. Okay, let's assess your hip mobility. Let's just sit down in your chair. Cross one leg over the other like you're putting socks and shoes on. How difficult is that? Is it significantly more difficult on one side than the other? Okay, maybe we check internal rotation of your hips too. Okay, now let's check out the nerve, a nerve tension test called slumps test. You're sitting down, rounding forward, chin down, and straightening one leg at a time, pointing the toes to the ceiling. That's a nerve tension test. Does that flare up your symptoms, increase the burning or electric shock sensation down the leg? Okay, great. That right there could be a great movement analysis to determine what are the primary triggers of that individual. So maybe some people, they're mostly triggered with forward bending motions. That's going to be the majority. Majority of people with low back pain, disc, and sciatica issues, they're going to notice more pain sitting long periods, bending forward, forward-based load. But other people might not. Like if they're, let's say they're an older population above the age of 65 and they have radiating symptoms down the leg, they could be more in the stenosis category. And for them, bending forward does not increase their symptoms at all. Extension does. Going to the shopping cart sign, right? Walking at the mall for a long period. Okay. a movement analysis would help us get a closer idea of what their triggers are, what makes them worse. And if you can find things that make someone worse, then it means you can find movements that make them better. Because these types of issues, these low back issues, these are movement-based problems, and they need a movement-based solution. So thorough history, movements, this is what a good assessment encompasses for low back related disorders.
Why do you think what you just described, probably in my estimation, describes like 20% of low back assessments? Why is that? Is this energy, like that it takes that extra little bit? What's your thoughts on that? Why is that not most people's experience when they go in?
Yep. I think this could be more opinion based on me. I don't have a lot of research to back this answer, so other people might disagree, and that's completely fine. But first off, what is the main point of entry for most people with low back pain? Well, majority of people see primary care providers when they have low back pain. Are primary care practitioners or general practitioners trained in low back pain? No. So I want to be very clear here. I'm not pointing a finger at anybody, because I'm not blaming general practitioners or primary practitioners for not knowing how to manage this, because they're not trained in it. Okay. Yeah. If someone came to me, a low back rehab expert, for an eye issue, I would not put a lot of pressure on myself to diagnose that.
Like, can you move them? Can you see me? Oh, yeah, all right, you need to go see this guy.
Yeah, but I would appropriately triage. And that's the key point here. So people are going to the wrong point of entry for low back pain. You should not be going to primary care providers. You should not be seeing a majority of medical providers. Now, I do know some awesome osteos and DOs, and I do know some awesome just general medical providers who have gone out of their way to self-educate and to learn from people like me. But those are not the majority, and you will have a difficult time finding them. So if we're just walking in general clinics, going to primary care, they don't know how to treat you. They don't know how to treat you. They're going to do what they know. They're going to do what they're trained on, which is the biomedical model, which is going to be, hey, pills, injections, imaging. That's what they know. So I don't necessarily blame them, but they need to appropriate triage and know, hey, I'm not trained in this. I need to refer to someone who does. And society also needs to be aware as well that that's not the appropriate individual to see most of the time as your first point of entry. Now, let's say they're like, okay, I know I need to see a provider like a chiropractor or a physical therapist because that is what they specialize in. They specialize in low back pain. Well, then here's the second layer. Okay, congrats. You're going to the type of provider you should be seeing, but are they evidence-based? Are they invested into their care? Are they a good provider that provides a thorough assessment and provides a movement-based approach? Well, guess what? Majority still aren't in that category. Yeah. So even if you go to the right bubble of people, still a majority of them are going to provide a minimal assessment. They're still going to utilize imaging more than they should. And they're not going to provide a thorough movement-based evaluation. So most people go to the wrong people to start. When they do go to the right people, a lot of providers just didn't invest a lot of extra to becoming the most evidence-based rehab movement, providers that they can be to get optimal outcomes.
Yeah, I agree with a lot of that. I do feel like part of it is like the like auto programming that happens. Like you come in, it's low back. We try and categorize it based on the structure that we think it is, not the function. It's always interesting. I'm sure you get a bunch of questions on like, is it my sciatic? And you're like, well, that's not a diagnosis. That's not the problem. Mm-hmm. We're just telling you like the structure that we think is at least involved. I feel like that, talking about semantics, that little small thing can cloud our judgment a lot of doing like symptom descriptions as the problem, as opposed to like, let me see what your functional deficits are, and then let's start there. Can we work from that angle backwards? I don't know. What's your thoughts on that?
Yeah, well, I'll kind of hone in on one particular piece there. Is like, is it this? What is this? My mind just goes back to imaging a lot, but a trap that a lot of individuals will find themselves in who are dealing with pain is feeling like they need to see what the problem is, or that they won't trust their provider if they're not ordering imaging or they're not telling them exactly what it is. When in reality, it does not matter a majority of the time. movement is going to tell us the direction we need to go. We don't need imaging to tell us functional deficits from someone. Like an image doesn't tell me what your range of motion is, what your strength is, what your history is. An image doesn't tell me any of that. So if they're looking for, well, what, like, is it my, like you said, sciatic? Okay, well,
Yeah.
what does that really mean at first? But is it that? Do you have an image on that? Oh, you're not sending me for imaging? Okay, then I need to see someone who will. Like, like those are the things that stand out to me the most that I think hold people back from actually getting better than if that wasn't the primary focus.
Let's navigate that a little bit. So if we're taking somebody and we're going through some of these movements, what's the thought process around it? Are you thinking at all in terms of what structures might be causing their pain when they go through these particular movements? And then the follow up to that would be like, all right, well, now what do we do about it? Like what can people do about it? But when you're looking at these things, how are we identifying maybe where the underlying pain response is coming from?
Yeah. So classifying someone to determine the appropriate plan is absolutely important. Not suggesting that it's not. My angle was more so from the viewpoint of the individual being obsessed with a diagnosis. Give me a label. Give me a label. That is not helpful for majority of people. Do we want to tell you what's going on to empower you and help you get in the driver's seat of your own journey? Yes. And so educating you on what's going on, what you can do to fix it is literally what we do online with people all over the world. But obsessing over the diagnosis is not helpful. So like small delineation between those, but I wanted to separate that a little bit. So if we perform a movement-based evaluation with someone, absolutely, we are still trying to classify them appropriately. So let's take a classic disc issue. If someone's like, I have low back pain, and I'm not sure what's going on. Okay, how do we go from that to, yes, you have a disc issue, we can fix this? All right, well, basic history, okay? What happened when you did this? Let's say the individual says, yeah, I was dealing with some low back pain that was increasing over a few weeks. I was in the gym, did a heavy deadlift, felt a pop in my low back, and then was very difficult standing upright the next day. Okay, well, that's a hallmark mechanism of injury for a disc. And then let's say it's been a couple weeks since then, and now they notice coughing and sneezing increases their back pain or radiating leg pain. Okay, another hallmark symptom. How does it feel, first thing in the morning? Way worse. Okay, well, we know discs swell over the night, so typically disc and sciatic issues are worse in the morning. How do you feel sitting long periods? Sitting really, really bad. Okay, so all of these things are basically positive signs for disc-related issues. So we can be very, very confident in telling this individual, yeah, this sounds like a disc issue. So most of the time, these types of flexion intolerant, meaning they don't like forward-based motions, these types of flexion intolerant discs usually prefer extension. So let's start with some regressed basic extension movements. So let's say we start doing extensions and then their movement gets better. Okay, so we have a slew of tests that give us positive signs for its likely disc. If it's usually disc, these types of movements usually improve. So then if we do the movements and they improve, that's another layer of positive indication that this is in fact what we're dealing with. So exercises that help are also equally valuable in the diagnostic process because they tell you what the structure in that scenario is. So yes, we can narrow it down in that format. Let's say they mostly have radiating symptoms down the leg and they might have felt a pop at, some time ago, maybe not super relevant. And they do have some back pain, but let's just say it's mostly leg pain. And a lot of the flexion-based things don't flare them up a whole lot. Like maybe they do have some pain sitting long periods, maybe bending over to touch the toes, flares up their leg a bit, but doesn't bother their back too much. Okay. Then we do, let's say, typical extensions, and they're non-responsive to extensions. There's many different extension variations. There's many different movement formats we can pick from, but let's just say they're not responding to movements of the spine. Okay, well, they have leg symptoms. That's typically generated from a disc, but this is starting to not look like disc origin. Okay, maybe it's a neurodynamics type route, which would be focusing on the nerve root, nerve inflammation, nerve mobility. Maybe that's where we need to look as a second layer because the spine is not responding to these types of movements. So then we would go to a category of other subclassifications of nerve dysfunctions. There could be closing dysfunctions, opening dysfunctions. Hey, let's put this person in what I call an opener. Let's just lay them on their side. Let's stack some pillows under their waist. Let's open up the side of their spine, open up the IVFs. Let's let the legs hang down. Let's let that IVF just open up and breathe for a while. Let's hang there 3 to 5 minutes. Okay, get back up. You feel better now? Oh yeah, that worked. That works significantly. Okay, our focus is no longer the disc. Our focus is now the nerve root. And then that's the formula that we would create for them. So diagnoses from, I got to know what the problem is and stare at it, that is not helpful. But classifying and determining where we need to focus and providing education on that absolutely is imperative for both them and for the treatment approach.
So somebody who's listening to this and they're like, okay, you nailed it. Like I have this kind of flexion based kind of disc irritation. What can their day look like that actually starts to move their healing process forward? Is there stuff that you're like, don't miss this. This is the brushing your teeth of your spine. Like do these every day. And then here's maybe like some training ideas that you might want to work in, kind of throughout your kind of exercise routines.
Yeah. I'll start as general as you can get, because obviously without an individualized assessment, this general will apply to most people. Specifics won't apply to everyone without you jumping on a call with us. So first off, it's imperative to maintain as many of your normal daily activities as possible. So one of the worst things you can do is get low back pain and then put your life on hold. You wake up the next morning, I have back pain, so I'm not going to go on my walk. I'm not going to go to the gym. I'm not going to go ride bikes. I'm not going to play with my kids because I'm afraid I'm going to damage my back further. That's actually one of the worst things you can do. So maintaining normal daily activities is one of the best things. Beyond that, morning and evening walks, extremely helpful. Not only for a multitude of biohacking purposes, honestly, like getting sunlight in your eyes, restores stem cell generation, wound healing, good for circadian rhythm, syncing. If you sleep better from seeing sun in the morning and sun at night, if you sleep better, you're going to release more growth hormone. You're going to reduce pain sensitivity. Like getting really good sleep is important. So morning and evening walks can do that. But just getting blood and fluid moving throughout your body, throughout your spine, throughout your hips to start your day is a great general approach. Like walking in general, super, super, super underrated. Like can be really, really powerful. So general practice, don't stop daily activities, walk in the morning, walk at night, move as often as possible. And don't be afraid about your posture. Don't freak out about it. Oh my gosh, I'm going to die because I sit with a slouch position. No, just move into as many different postures as you can throughout the day. So that's as general as I can get, but could be extremely helpful and powerful for the individual who does not know that. Now, if you are someone and you're saying yes, 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 yes to the sitting long periods, bending forward, coughing and sneezing, difficult to stand up straight after sitting long periods, these are all very closely mimicking a flexion intolerant issue. So most the time, not all the time, most of the time, starting with extension-based movements is going to be the right place. So what does that look like? It looks like doing everything I mentioned earlier, but also incorporating some basic movements where you might lay on your stomach. Maybe we just start by propping up on the elbows. So you're in a little bit of a sphinx pose like in yoga. You're propping up on your elbows and you're just allowing yourself to rest in that position, regain some of that arch in your lower back. And you can perform this repetitively. So lowering your chest to the ground and pushing back up, lowering your chest to the ground and pushing back up. And if you notice that it's really tight at first, but the more reps you do, the easier it gets. It's because you are unlocking that obstruction that's blocking your movement. You're actually reversing many times the disc bulge that's blocking the motion. So then if it gets easier on your elbows, then progress to your hands. Put your hands under your shoulders, push your chest up off the ground, keep your hips on the floor. This is a progression to that. Once again, now that might feel a little bit stiff again, might even cause a little bit of pain. But if you gently just kiss the pain with every rep, don't push past it, just kiss it. If the pain gets less and less and less, and your mobility gets better and better and better, you're going the right direction. Your symptom response is what dictates what we do with movements. And you might try movements where the symptom response is not favorable. That tells us we do not want to go that direction. But if you do a movement and your symptom response is very positive, then we do go that direction. So your symptom response determines the right exercise for you, not a piece of paper or not a diagnosis.
I love that. Let's unravel this spine is fragile kind of idea that gets perpetuated and thrown around so much in healthcare, in conversations, in media. I feel like it's one of the things, if we could get one thing across, that this like fragile spine, don't move the wrong way, don't sneeze, don't do it. I got you perfectly, you know, aligned, positions, you name the term. Um, what's the spine meant for? Why is it not fragile? Unpack that for me.
Your spine is not fragile. It's not made of glass. Although there are so many providers that make you feel that way, that if you're not walking perfectly straight, sitting perfectly straight, or something's out of alignment and you're susceptible to injury at every corner, and that you can't even bend over to pick up your phone without having a perfectly straight back, otherwise something's going to go out.
Yeah.
Yeah, that's the thing that's creating chronic pain and is trapping people. When in reality, your spine is incredibly strong and robust. It is literally one of the strongest structures in your body. It is jam-packed with muscle. It's jam-packed with connective tissue. It can adapt to load. So just like other muscles in your body can get bigger and stronger, so can your vertebra, so can your discs, and your discs can adapt to load too. So having this concept that we have to protect our back and it's susceptible to injury and things can go out and I have to move with this neutral posture all the time, that's only going to put people in an injury state. But knowing that, hey, your spine wouldn't have all these joints if it wasn't made to move, and it wouldn't be built as robust as it was if it wasn't able to handle load.
Yeah.
No, your spine's built to be strong, and you are strong, and it's not fragile.
Yeah, that if y'all are listening to that, like go like hit that little like 15-second back thing or 30-second back, whichever app you're on, and like re-listen to that. If there's one thing that starts to seep into your head, it's that your spine is strong. It has the capability to be strong and adapt and change to whatever you tell it to do. This is a weird story, but I remember being in cadaver lab, and us doing some dissections and people starting to mess with the disc and going through scalpels like crazy because the disc was so tough that you would, if you started to try and cut, you would wear your scalpel out in a heartbeat. And we were all blown away. Now, I'm from South Louisiana. We do a lot of hunting. And not to make this super graphic, there's times where we have to cut through that. So I was familiar with this. And I was like, look, if you're ever trying to cut through it, you're going to realize real quickly, this is not fragile tissue. You can twist and yank and pull and do all this stuff. You're going to be sweating before you get any change to the disc tissue. But I do remember our classmates being like, and this is the stuff that we thought, like me slouching and me moving here, I was like damaging it. You know, obviously everything has, you know, a gray scale to it, but it was amazing just how tough this tissue is.
Yeah, it is truly incredible. And it's such a shame that people aren't being instilled with that confidence when they're in an injured state, and that they're instilled with the opposite. Like the number of people who experience a common disc injury that are told, yep, you're not going to work out again. You're not going to run. You're going to need to stop doing all these things. Like you're going to need to learn how to manage this the rest of your life.
Does that make your blood boil even just like saying it?
Oh, it's unbelievable. Like I can't imagine like witnessing that. And the sad part is a ton of people are told that message.
Yeah.
Like this will not heal. You now need to be careful for the rest of your life. And something as simple as like, and listen, there's other chiros and PTs that I know that we'll get referrals from who are told, yeah, I know that I'm going to hurt my discs if I don't practice neutral spine when I pick groceries off the ground. And I'm like, so you're under the impression that picking up a gallon of water with the wrong posture is going to slip your disc out and is going to put you in an injured state. And you need to be neutral to do that. Like, yes, like I know, like I'm going to hurt myself. It's like, oh my gosh. Like, but then you look at, strongman and they're deadlifting 1,000 pounds with a rounded back.
Yeah.
Like what? No.
Yeah, I mean, I'm glad we're having this conversation because it always puts us in a little bit of a tough spot. And I'm sure you've been here where they're like, this surgeon who I trust told me this. This other doctor who I trust told me this. And it's it's a slow process, right? We are always like, look, I'm sure they have a reason, right? I don't know what that is, but here's what we know. Here's the studies. Here's the research that we're going to try and pull from when we make a decision on this. But it does make things a little bit difficult to unravel that, let's call it education. What's your technique around that? This is self-serving question. Like, what have you seen to be effective to that person who thinks that? Have you seen some full transformations of somebody like going from that belief to like, oh no, I've got a bulletproof spine. It'll learn to do whatever I tell it to.
Yeah. So you just nailed it. One of the words you just said, belief. So we're dealing with a belief system, and dealing with a belief system, you gotta have some tact with this. So you're absolutely right. We will talk to some people who are in love with their previous provider. They might be their best friend, or they might just love the way they make them feel. And that's great. That's awesome. If you're with a provider and they make you feel good and they treat you well and you like them, that's awesome. It doesn't always mean that the narrative included though is the right one, sadly. So when we're talking to someone who, let's say that's what they said. Hey, I know the reason for my pain is my posture, let's say, when in reality, it's not at all related. So like, I know my pain is my posture because my last, PT or my last chiro told me that, and they're amazing and I love them. And we go through some of the things that they were told, and we're like, man, this isn't accurate. This isn't accurate. This isn't accurate. Okay. How do we change a belief system from someone who really likes and trusts their previous provider? Well, a delicate dance. I would say first off is anything that you're going to say that counters what they were previously told. You need to make sure you're not suggesting in a way that is putting down the other individual. If you for a moment begin to suggest that last provider who they believe is, wrong or incorrect, you're going to lose them because they will take that personally. They shouldn't take it personally. They shouldn't, but they will. So I love my last chiro. He's amazing. Well, your last chiro was wrong. Screw you. Can't do that. So we need to always highlight the positive components that they were given by the previous provider. So that's step one is, hey, well, here's the really good things that you got from them. So I'm really happy that you were encouraged, or I'm really happy that you were told this. Those things are really great. And then suggest, okay, now these other things, considering you are still experiencing this pain and you're not recovered, do you think these things you might have been suggested have been helpful in helping you, find a solution? Hopefully they realize the answer is no. Oh, well, I was told to do this, but I'm still in pain. I'm in the same situation. So likely they did not help. Okay, are you willing to try some variations of that or some alternatives? Well, sure, I'm consulting you for help. Okay, great. Then how about for the time being, just to see if we get a different response, we could alter that to this or change it to this or try this to see if we get better information to know how to move forward from here.
Yeah.
To try to build a framework for it, that's the best way to manage that without stepping on someone's toes or creating conflict in regards to these belief systems. You have to.
What do you think posture? Well, I think we should have to define posture because I feel like there's so much baggage with what that means. What do you think of as posture? Like do you have a definition of like what that is?
Yeah. So what is posture? It is the way you look at one singular point in time. That's what it is. So if I tell someone, hey, the reason you're in pain is because your posture is bad, then my response would be, when? When was it bad? I can't say it's bad to paint a broad stroke over the last 5 years. So posture, in my opinion here, posture is if someone walked next to me right now and took a single photo, that is a posture. I am in hundreds and thousands of different postures throughout the day. So blaming someone's pain on posture is a huge disservice to them.
Yeah.
Now, I'm not saying people's pain can be increased cannot be increased in certain postures. That's not true. As I said earlier, a lot of people with disc issues, they'll notice the longer they sit, especially in a rounded position, the worse their pain will feel. Well, Grant, isn't that posture? Doesn't that mean my posture is causing pain? In that context, yes. but that's not what caused the pain. And adjusting your posture isn't going to be what fixes it. So we don't want to label that as the primary generator. And we don't want to make the narrative that that's the thing. So for that individual, I might recommend they have a lumbar roll or switch to a standing desk to get out of flexion throughout the day. But the thing that's going to fix them is not changing their posture and making them obsessed about their spine positioning. The thing that's going to fix them is fixing the disc. And then they can sit in whatever position they want as long as they move frequently. So the evidence shows us that curvatures of our spine or posture does not cause pain. There's no causational relationship. It does not exist. And that's a helpful one I'm going to bring up again. Curvature of your spine, there's no conclusive evidence to suggest that the shape of your spine directly causes pain. Now, highly progressive scoliosis, that's a different category. I'm talking about common variances in spine shape and structure. Does not automatically cause pain. So when we get back to posture, it's okay. That's not the reason for your pain. If it causes you pain, let's modify your posture for the time being to get you through the day. But the goal should be for you to be in as many different postures throughout the day, because the best posture for you is going to be the one you're in for the next 5 minutes.
Yeah. Yeah. I don't want you in less postures. I want you in more. And I think this is where I love that definition, because we get asked all the time about sitting. And I think in the studies I was pulling up, it's like we're at 9.5 hours a day in the US now is what the average sitting time for an adult is. And I think the problem with that is everybody's like, oh, well, it's like the danger is sitting. You're like, not necessarily. But the danger is probably sitting for 9.5 hours. You just limited the number of postures you're getting into for this giant expanse of time. What do you, when someone asks you about sitting, what's your answer on that? I know I just colored that a little bit, but.
Yeah, I want to respond, and I might answer the question you want me to answer directly, but I want to respond to what you just said first. So here's what I would say. Someone who sits for 10 hours a day, but incorporates a 15-minute movement break every hour, that's probably a better scenario than someone who sits 5 hours in the same position without moving, without any breaks. Because the problem is not the sitting. The problem is how long you're in one singular position without movement breaks. That's the problem. I don't care how you look when you're sitting. I care how often are you not sitting? How often are you in a different position? And one super cool study, this was looking at disc hydration throughout the day for people who take movement breaks versus those who don't. They did MRIs and they looked at people who sat without movement breaks, the amount of disc dehydration from the beginning of the day to the end of the day. Okay. So they evaluated that. Then they implemented a 20-second movement intervention every 15 minutes. So just 20 seconds. And all they did was they stood up, they bent forward for 5 seconds, back for 5 seconds, left, right, 5 seconds. That's it. And they sat down. They did that every 15 minutes. And in that same group where when they weren't doing movement breaks, disc decreased a lot throughout the day. Then they implemented that and it didn't change. It was the same height at the end of the day, or at least not statistically different. So small amounts of movement can make a very big difference. So if someone says, hey, I sit most of the day, I go, so do I. How often are you moving though? And how often are you changing your position? That's what matters.
So good. So good. Yeah. Like those little snack movements, little snack exercises, the amount of change that we can create with some tiny little inputs that set off this chain of reactions, it doesn't cease to amaze me. Like I hate the word for it, but it got a lot of press whenever Huberman talked about it, like the soleus push-up study where they just sat and like pumped the calves. And it's like the things that change, like blood sugar regulation, energy, blood flow, muscle activation. You're like, they're like moving their feet. That's it. And you're like,
yeah.
If you stand up, bend, and that's what I need to do, and that gets me in different postures and keeps me from dehydrating and just shutting everything down. Yeah, it can be that easy.
Easy. Yeah, not hard.
This is a curveball, but what do you see as where do you see manual therapy in the recovery process? What do you see manual therapy doing? What is it not doing? Obviously you've got chiro training. And so, yeah, I know there's a lot in there that's like, what can adjustments do? What can't adjustments do? But how do you think about manual therapy's role in the recovery process for, spine issues, back issues, really anything, but.
Yep. To translate a really digestible concept here, I always just say 80-20 rule, where 80% of your care should be in an active therapy bubble and 20% doesn't have to be, but can be in a passive therapy, manual therapy bubble. So we all know, and this is based on the evidence, this is not my opinion, the number one treatment for musculoskeletal pain is education and exercise. Education, exercise, number one treatment for musculoskeletal pain, especially low back pain. That is fact, not my opinion. So can manual therapy like adjustments, soft tissue work, needling, whatever, can those be helpful? Sure, they can be helpful. They are not always needed. Sometimes in rare circumstances, they could be the thing that helps the person, achieve a greater level of recovery. But majority of the time, not needed, but they can be helpful. The problem would be if that is consuming 80% of your care and movement and education is, shoved to the side, like, the ugly stepsister that people don't want to hang out with. Like, no, like that needs to be the primary emphasis. So I have no issue, obviously, because I just follow evidence-based practices. So if someone enjoys the experience of being adjusted, if someone enjoys the experience of having soft tissue, well, could that provide a healing component to their plan? Yes. So I'd say, yeah, go for it. But as long as their belief system does not turn into the only way I can get better if someone is releasing my muscle or adjusting my spine back in place, and I need them in order to stay like that, that is the problem. So 80-20, as long as at least 80% of your treatment plan is education, exercise, and if you have any, it's about 20% of manual therapy, passive therapy, then that's a good ratio.
This doesn't get talked about a ton in the healthcare model. How much do you think kind of like emotional, mental belief, anxiety affects low back pain and recovery?
Absolutely massively. Huge. Belief systems, man. Yeah. If I talked about this earlier, but I'll say it again. If I'm someone where my belief system is, I'll give two polarizing examples. Okay. Oh yeah, my dad had back pain one time. No problem. He was fine the next day. I know that you can recover back pain. I know back pain is no different than stubbing your toe on a dresser. I know my body's strong and resilient. Okay. I have that mentality. I wake up with back pain one day. No big deal. It'll be gone tomorrow. Okay, great. I go on with my life. The other person, I have super stressful job. I have, emotional struggles. I have, maybe I'm in the process of going through divorce. Okay. Maybe I'm in the process of losing my job. I have a lot of stress and burden on my mind, combined also with, my dad had back pain. He's never been the same. Oh, my grandpa, he had 6 spine surgeries. And then I do a very normal thing. Let's just say it's a day where I sat too much. And no big deal. Sat too much. Back was just a little bit overstressed in one position. And I wake up the next morning, I have some back pain. My response to that could be catastrophic. And that could release all this emotional stress or trauma that I've been holding on to, combined with my belief system. And that could take what would have been a 24-hour bout of back pain to a 24-month experience of back pain. Yeah. Because of all those other things that I have going on. And a really strong story to hit this home. This is true story. I want to tell any fake ones, but in case some people might think that. We had a client, her name was Gabriella. She was out in Brazil. Classic disc hitting a nerve, shooting down the leg. We had her symptoms like completely centralized within like 8 weeks. Like went from debilitating pain, I've been told I need surgery from 3 surgeons, to like pain-free in 8 weeks. So like crushing our program, absolute home run client. And so she's just cruising. Life's good. And then all of a sudden we get a message from her and it's like, something's wrong. I did something. All of my pain is back. It's radiating down to my foot. I can't move. Like, and we're like, okay, what's going on? So we message her back. Hey, what happened? Did you do anything different? No, I didn't do anything different. My routine's been the same. My exercise been the same. Okay, so like you didn't try to do more in the gym. You didn't try new exercise. No new exercise, nothing different. Like I did something, I'm crying. I'm starting over. We go, okay, there's something that's going on. We need to get on a call. So we get on a Zoom call with her and we just start talking through these things again. Like, what's changed? What's different? And, everything's the same. No different exercise. I've been following the plan. And then I ask her the question, okay, and I just want to ask, has anything happened recently to any, friends or family members or anything like that? And she completely freezes. She starts bawling and she says her friend died about 3 days ago. Her best friend died. And the day she messaged us that all of her pain and symptoms came back was the day after she got the news that her friend died. So obviously you have to handle this in a delicate situation, but we spent some extensive time educating her that because she was very confident that she didn't do any new exercises, there were no falls, she didn't do anything out of the ordinary, then that is proof that she could not have re-injured her spine or her disc or her nerve. That is not a worry that I didn't do anything, but it's back. No, that's a good thing. We know for a fact no injury occurred, no damage has taken place. We know that for a fact. And then we helped her realize that this was an emotional outlet her body used from a previous, very recent and on her mind injury that her body's currently using to process trauma.
Yeah.
And we had that conversation, and within 48 hours, her pain was 100% gone again, like she was literally 4 days prior. So it's very
powerful. I feel I've talked to a lot of doctors on here and asked them kind of, why don't we have those conversations more in clinic, in office, with our patients whenever we have that, is like asking that question. Because there's many people who they would have done that and reached out and been like, shoot, we tried our way. Maybe you do need to go get. The funny thing is we always, like, whenever we get that, we always like knee jerk back to like the old negative patterns of like, oh no, well, maybe you do need an MRI and maybe you do need the inject. Like, you know what I mean? Like we were going to try it. We were going to try it. Oh crap. Just go do it. And like, you got me nervous, and now I like doubted everything that I was doing. I see it a lot. But the other part is that we don't have a great, I think a lot of doctors don't have a great tool chest if the answer was yes, as you said. Like they don't quite know what to do with that now, other than refer them to a psychologist, psychiatrist.
Yeah. So to your point, two things there is like, one, we need to know how to have those types of discussions. I'm not suggesting we should not refer to pain psychology. We do.
Yeah.
We have a pretty good grasp on pain science and pain education. We incorporate this into our program. Like day one, we're incorporating pain science, pain education to help people understand these concepts and to feel more in control, because the more one understands their pain, the more they can control it, the more they can reduce the sensitivity of their nervous system. So that's really important. So if you feel as though you're in territory where you're not qualified for, absolutely refer to pain psychology for sure. The other thing is you just said, hey, we might like freeze and think, okay, maybe this isn't right for you. Well, this is a perfect example to say, let's pretend that we were the non-evidence-based, non-adequate provider. And the same scenario happened, and we didn't appropriately analyze the situation. And as soon as she said, oh my gosh, all my pain's back, something happened. Remember, she was only 8 weeks in. What are the chances that a disc herniation is still present on an MRI? Extremely high. So if we had done that, oh my gosh, we don't know what's going on. Yeah, just go get an MRI. Maybe this can't be resolved with, our program, even though she was literally pain-free 2 days ago. Then she would go get an MRI. There would still be presence of a disc on the MRI for sure. And then the clinic, the hospital system she's at, they're not asking about personal life trauma and emotions. They're not asking any of those questions. The only thing they're looking at is, oh, you have pain. You're saying you're in a lot of pain. Oh, there's a picture with a disc. Yep. And you just tried rehab. Okay. Yeah. Let's get you in for surgery. Absolutely. She would have had surgery.
Yeah.
100% she would have had surgery if that's what we had done. But we saved it twice, technically the first time she started and the second time, getting things back on board from this emotional flare up. Yeah, we prevented surgery twice.
Yeah. I love the idea. I'm going to use you did nothing. Okay. Well, then that's proof that nothing got I love that. That's powerful.
Yeah.
That probably is like a little switch, like, oh crap, he's right. Like I didn't do anything. I couldn't have made anything worse. I didn't miraculously do something that blew this out or threw it out or whatever language. I like that. That's powerful.
Super, super helpful reframe
Yeah.
because like what you're realizing, people treat it the opposite. They go, oh my gosh, I woke up today and my pain's worse. Like, something happened. I'm damaged again. That's how fragile I am. That I can slip into injury again. When it's the opposite. It's, hey, wait, did you do anything different? Did you do any new exercises? Well, then we know for sure nothing is damaged. So now let's talk about things outside of that
Yeah.
that could be related to this pain experience. So, hey, did you have a stressful day yesterday at work? Hey, because you were feeling good, did you go and eat a bunch of pizza and cake and have way more sugar or gluten than you're normally used to? That could have inflamed your body just for this time being. Okay, that could be it. Sometimes it is. Sometimes it's
Yeah.
things as simple as
I mean,
this.
look, we're in South Louisiana. We started noticing very, very heavily. We track a lot of things in our office, and the weeks after Mardi Gras, I don't know how familiar you are with Mardi Gras, but life habits go out the window for a little while, and there's not a lot of healthy things being done. So lots of things flare up somehow that like week or two after, and everybody's like, I did something, same conversation. You're like, well, hang on. How was diet? How was alcohol consumption? How was sleep? Like let's just before we think that this was a mechanic thing, let's look at some other stuff before you kind of think that you're fragile from some weird movement that you did trying to jump and catch a Mardi Gras bead. Because I venture to guess that that's not the main fire that we have to put out right here.
Yeah, 100%. Like, oh, you're telling me you slept 4 hours a night for the last 3 days? That's probably related.
Yeah,
Like,
yeah, you did that, and you drank a case of beer, and you were eating fried foods for the last week. All right, don't freak out. Let's clear that stuff up.
Yeah.
There's so many people dealing with this stuff. What can we prevent to a degree significant or persistent low back pain? Like, is that something that you believe is possible for most of the population? Like, right now they're like, I haven't had it. I don't have it. Can I prevent myself from getting into this problem area?
Yeah, here's where I can confidently step into a gray area where really evidence-based guys might go against me right now. Because on one end of the spectrum, if we look at like sports-related injuries, injury prevention, the claim is always this, is, hey, if we knew how to prevent injuries, then injuries wouldn't happen. So it's impossible to prevent injuries. Okay, part of that is true. So I would never make a claim that, yeah, we can help people, prevent low back injuries. That's not all the way true either. There's absolutely a middle ground, because although the evidence, there's no conclusive evidence that says we know how to prevent injuries, you're right. Then no one would be getting injured. That would be published everywhere. Everyone would know, oh, I just do these things, I'll never get injured in my life. Yeah, obviously not possible. But if someone is aware, let's summarize a few things. Let's say I'm at least aware that back pain is a common experience. I'm going to experience it at some point in my life. It's not a matter of if, it's just a matter of when. But when that happens, I don't need to panic. That rate of recovery is super, super high. And before that happens, I'm going to begin incorporating a good diet and regular exercise into my life right now. And I'm going to implement some spine mobility based things to keep my spine as mobile in as many directions as I can right now. Could having that understanding, education, lifestyle habits, and mobility already established help reduce the number of injury experiences that person would have in their life? I would be willing to put a lot of money that says that would be successful. So absolutely, I would stand firm in saying that will reduce the injury occurrences, and it will reduce the incidence level and the duration of time that individual is dealing with that injury, for sure, by having, once again, the knowledge and the education, the practice ahead of time.
What's your favorite exercises that are targeting spine health?
Yeah, so super general. So our spine was meant to be loaded. We need to load it. So honestly, what I would say, if there were, here's what I'd say. 4 things immediately come to mind for, like, if you just want to keep your low back healthy. I would do a stability movement. I'm going to say what these are: a stability movement, a mobility movement, and then two main loading patterns on the spine. So mobility. Once again, majority of us are in seated positions most of the day, 9.5 hours, as you said. We're getting a lot of flexion. We're getting a lot of bending forward. Majority of individuals, we need more of the opposite. We need to be restoring extension by equalizing the stresses in your body. So if I had to pick one mobility movement, I'd pick the repetitive cobra. So laying on the stomach, pushing up into extension repetitively throughout the day. You could do that once in the morning, once at night. Restore the extension. Stability movement, dead bug. I love the dead bug exercise. It's phenomenal. Most disc and nerve issues will not flare up with it. It's very low back friendly, but high ROI. So it teaches intra-abdominal pressure, how to use your diaphragm, good core bracing, really great ROI stability movement. And then two loading patterns. We need your spine to be able to hinge with load and to be axially loaded. So deadlifts and squats, baby. So like, if there are four things I could tell anyone to do, it'd be lumbar extensions, dead bugs, squat, deadlift. Just like do that, and like you're going to be pretty solid.
I love it. Yeah, that's good. I cannot refute or go against any of those. I agree with all of those things for sure. Grant, where has your thinking been impacted in this world? Like, were there people that jump out to you? Were there classes? Were there studies? Like, who's impacted your thinking on this stuff the most?
A collective pool of influences. I don't have any one individual that changed everything, but I think anyone who's good at anything is always seeking for as much information, mentorship, and coaching, and as many aspects of that as a very, very forward-thinking process. So, of course, I would say initially meeting, a rehab-based chiropractor that inspired me to do that obviously got me into this. But then always having the mindset, I think the best way to answer your question is this. I think it's having the mindset of wanting to be the best and knowing that you will not get that from a singular source will force you to be willing to invest into your education, invest into yourself, and always be seeking knowledge. So not being a know-it-all, being a learn-it-all. And so the amount of additional courses and mentorship that I invested into throughout school was extensive. Like my very first trimester, I did 3 seminars my very first trimester, and my classmates were like, "What are you doing? You've already spent $1,500 out of your pocket for courses. You're a Tri-1 student. You're still learning anatomy." And I was like, "I don't care. I'm going to learn faster than you guys. I'm going to do it now." Obviously I didn't really have that mentality, but I'm just making a point. Yeah. Like I was so ready to invest into additional education. No price point held me back. So being involved in as many clubs as I could be, as many extracurricular shadowing opportunities, courses, seminars, other great social media accounts and locations that produce evidence-based, high-quality information, just consuming as much of that as possible. Like that's just all I did for years and years and years throughout school and even now. Like just having a humble acceptance that I can always improve and be better and there's more to know puts you in a position of always seeking more information to be better than you are right now. And that's ultimately what it is.
It's tough. I'm sure you get this question a lot. Like, hey, how do I find somebody like you, or how do you recommend a practitioner in my area, or any of those things? What's your answer to that?
Yeah, so that's a tough question because vast majority of individuals in any profession are inadequate. That's just how it is. Yeah. So like it's going to be tough to find a good medical provider to help you with low back issues. So there's 2 things that I would say. Well, the first thing I'd say is that's why we're the #1 online program. It's because we help people who are struggling to find help in their environment. So we have clients in the US, Canada, Saudi Arabia, Australia, New Zealand, Japan, everywhere. We have clients everywhere, and we have consultations every week on like every continent. So that's why we do what we do, to make a greater impact across the world and to get this information and the right guidance and the right rehab to them. But that there's an individual that I guess isn't looking for that and they're looking for some type of local service, then the best type of guidance to provide is to just say, look out for the key hallmarks of evidence-based approach, which would be during that appointment for low back pain, are you being fed a lot of scary words about the fragility and that your chance of recovery is very low, and the only way that you can be fixed is through that person, and you're going to need to be there forever. Those are red flags. Are they immediately pushing you to injections, imaging, or surgery? Those things are red flags. Of course, there are instances where there could be surgical emergencies for low back related things, but these are very, very, very rare. I'm talking about the majority. So, yeah, I mean, if you're being pushed to imaging, fed negative messages, scary messages, being told to stop doing everything and not being taught how to fix yourself, those are all red flags. That is not a provider that I would continue to pursue treatment with.
Yeah, I bring that up because when you explain like your education drive and like thinking around that, I'm like, that's who I want people to see. But to say that is like, it's a challenging thing. So I'm always like, reach out and ask for CVs. You don't want the person who's coasting. You want the person who realizes that they'll never know enough. If it's, oh, well, they've been in practice 20 years. That's cool. What have they done in the last decade? Like, are they still? Yeah. It's always a little bit of a challenge because people bring it to us and I'm like, there is not a place that I can go to like look up something and tell you this practitioner in, blank, Texas or California is great. It's like, it's unfortunate of the world we live in, but are there particular accounts that you still consume their information or follow that you feel like put out good information, good education online?
Let me try to think about some main ones. I mean, I've been following similar accounts for many, many years since I really started growing my social media and pushing social media and things like that. This might be a delay by my thinking
All
pattern
good.
on this podcast right now. Uh, Man, it's so eclectic. I get a little bit from everything. I truthfully, I don't think I can throw out one singular account that I think would be like golden that would, or maybe feel comfortable putting like my name
Yeah,
directly
yeah.
next to, because
Right.
I think anyone, and you could argue myself as well. I think anyone has some really good information and maybe some information that you don't always agree with as well. So I don't think I'd be able to pick one singular location that's like, this is the gold standard for all information that I pull from. So sorry, I don't have a good answer for that
Oh,
one
no, no,
question.
it's all
I
good.
think I'd
I'm
be, yeah.
always kind of probably the same. If you go through like, I'm not a massive social media consumer, to be completely honest, and my audience has heard me say that before. So if you do look through mine, it's like functional med docs, some form of like rehab based like movement, and then there's manual therapists, and then comedians. It's
Yeah.
like that's everything that's on mine is some version of those things. And then because my wife always looks up pets, I don't know if everybody, I have my assistant here
Oh.
who is working
Oh,
very, very hard. Yeah, good job, Duke. Thanks for the
slaving away.
support. Thanks for the support, buddy. There's a lot of dog stuff on there too.
Yeah.
Not to my own searching, of course. No. Um, Love it. Dr. Elliott, we ask all of our guests, if somebody's listening to this, they got a ton of takeaways already. But if they're listening to this and they could do one thing today to improve their health, what would that one thing be?
Move more.
Move more. I thought that might be where you went. Where can people touch base? Where can they follow you? Where can they kind of dive into more of your education? How can people get more from you?
Yeah. Number one place is Instagram. Rehab Fix is the name of my channels. Now I am active on all social media platforms. We have long format on YouTube, but Instagram is number one. And if you go to our Instagram and you message us the word podcast, you'll actually get a full training. It's like a 20-30 minute training where I actually go through basically a virtual analysis and assessment with you to coach you through movements that you can self-test, kind of a self-diagnostic process, and then self movements that you can begin to start with. I don't have this posted anywhere, but that's an opportunity for you to grab that. And of course, shoot me a message if you want more help, or go to our website, therehabfix.com, to submit an application for our program, and we can get in touch with you and help you get pain free.
Man, Grant, thank you so much. I know these things are time consuming, especially whenever you're trying to help people, but I feel like these conversations need to live out there. I appreciate you taking the time and energy to Get these out. They mean more. I know so many more people that are starting to change their thinking because they've heard a conversation like this. So I really appreciate what you're doing and putting it out in the world, man.
I love what I do, and I'll never stop doing it.
Thanks, man. Love it.